And here we are. Looks like we are good on microphone, good on volume. Looks like there's only 8 chapters left. Yep, that would be correct, which is approximately 2, maybe.
Justin,
You can't hear me?
you are now muted. You are now unmuted.
Can you hear me now? 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 Can you hear me now?
Yeah.
You can hear me now?
Yes.
Okay. I think that when I turn on record from the recording software that lets us post to YouTube, it kills the classroom. So that's just a lesson I'm going to have to remember. And if I just hit refresh on my screen, it goes right back. Okay, so to Aiden's question. Aiden said, looks like there's only 8 chapters. How many lectures would that be? Approximately 2, maybe 2.5. We're going to try to do module special pop tonight in its entirety because I'm going to tell you what to target. You're going to do the work as we have made clear in the class. I'm going to talk to the points that are most important for not only testing and for what you're probably going to see come your way in that avenue, but for practice, what you need to apply to these special populations of patients when we encounter them. So that's what I'm going to do. I'm hoping to get through all of special population tonight, which would be, if you are following along, it would be chapters 34 through 37, but that should be the same in your book. I'm gonna look real quick. It should be, and it is 34 through 37. I think that might be trying too much. Yeah, that is probably trying too much. I think we could get through operations in one lecture, but I don't think I don't want to do neonates and pediatric a disservice, so we'll make that 2 weeks. Okay, so we're gonna do 3 weeks, and so then the last week of class, April has 4 weeks in it, and so then that'll give us the last week of April and the first week of May to finish everything you need to finish, and so that's 2 weeks to finish psychomotor skills evaluation and to decide where and when you guys want to take the final. We'll discuss that when the time comes, and I will leave that up to you as to how we do when we do the final. Okay, remember that we are taking the trauma module exam this Wednesday and Thursday. I'll be at both of those days, so there's that. We will have open practice for skills again, and then the next week we will have some assessment stuff again, and we will kind of teeter-totter on that until we finish out the class. Right, let me pull up 34 and 35. We'll bring up 34 and 35 and try to get, we'll just do those 2 tonight. Kiara, I see you. Doing, close that browser, come into here. If you guys suddenly can't hear me, speak really quickly. The final I'll leave when we get to there. I will talk with you guys about how and when we want to do the final. I assume we would do it on the lab days, as we normally do, but those last 2 weeks of school, 3 weeks of school, are crazy for you guys. So, especially for those of you who, are in the collegiate courses. So we'll talk about that when it gets here. So I downloaded 35, but not 34. So weird. All right, that's pulling up. All right, let's take a quick attendance. Be ready to speak up. Let me turn this white. Jamie Beach. Jason Eater.
Jason's here.
Thank you. Courtney Mag is here.
Here.
Sherelle. Tia. Alexis. Shy. Shelly. Sydney. Julia. Aiden is here. Christina Saucerman. Mark Walker.
Here.
Alex Clark. Lucas Ackerman. Max Alderman. Ella Caston. Henry Williams. Dominique Rapian. Ava Mack.
Here.
Ava. Steven. Brooke. Kiara. Lemon is here. Sarah Ormond.
Here.
Ari Diaz.
Here.
Druvy. Bitch, I don't want you over there. Let me cuss somebody out today. Allison Kiernan. Dylan Williams. God, I hate technology sometimes. Normally my fault, but still. Video and Peds lecture. Okay. Okay. All right, so we'll start with obstetrics and neonatal care, and I want to say what I commonly say, but in this case it is again true. This is a really big chapter. And unfortunately, this module is extra difficult in the fact that not only are they special in population, they're also rare in population. And when we think about rare things in emergency medicine, we call those high risk, low frequency. The less we do things, the more difficult and challenging they are. And that's just muscle memory. That's just, having that familiarity brings comfort and it lowers the nerves. It allows you to focus more on the medicine and not on the emotions. And, that's always good for care. And that is why you have emergency board certifications that specialize in pediatrics. Generally speaking, the delivery of a baby is a BLS skill. That might be surprising to you, but that is true. How you determine that a baby is someone you should be delivering, let me deal with that real quick because that is god awful. And there are a few of these alarms on here that aren't. They're so horrible. I think let's do this one. Yeah, that one's not horrible to you. There are things we need to know in order to determine that you should be delivering this baby in the field. Even if that's a paramedic that's delivering the baby, we've got to do a good assessment on mom, a good sample, and a good OPQRST on mom to determine that this is a child suited for delivery in the field. The caveat to that is we don't always get to decide. there's a point in which the baby's coming and you have to stop and you have to deliver. You can't carry on down the road at 90 miles an hour trying your best to make sure this baby delivers in the hospital. Unfortunately, it lands in our lap sometimes. And so we're going to talk really heavily about interviewing mom, finding out about prenatal history. We're going to talk about some new things, new verbiage, new questions that you're going to have to add to your sample in OPQRST in regards to OB and neonatal care, and how it is that we end up arriving to a conclusion that although I wish we were in the hospital, we're not, and this baby, based on my assessment of mom, is okay to deliver in the field. And again, that's a BLS skill. One of the things the book is going to talk about, and I love to make a point of, is that women give birth. We do not birth babies. We don't deliver babies. We coach, we assist, we have a knowledge base, but we do not deliver babies. For centuries beyond modern medicine, women have given birth to children without doctors, without hospitals, without surgical interventions. And we wouldn't all be here right now if that wasn't somewhat successful. Do we hope that we're improving it with modern medicine? Yes. There's also data that says we worsen the delivery of neonates in the United States due to modern medicine and some of our approaches to the timing of delivery and not allowing the body to go through its individual processes, even when those fall outside of the data. So if you are familiar with that conversation and you know about the data that differs the United States fetal death rate as compared to other modern nations, I applaud you for knowing that. And for those of you who don't, we have one of the worst fetal death rates of any modern nation. And you got to ask yourself why that is. And so there's a big conversation about that. And we're going to talk in this chapter about you letting the natural processes occur. There's a point in which we need to do things. There's also a big recognition that needs to take place that this is going to happen with or without us. And so we got to have some respect for the body and its timing and mother and her effort in this. And so this chapter is to educate yourself about how to best coach, support, be there for, encourage mama, but we don't deliver babies. Okay. On the other side of that coin, what the hell do we do when it gets out here? That stuff is going to be bigger, I think, in the chapter than the actual delivery itself. Is how do we deal with neonates when they come out? Are they happy and vibrant and pink and beautiful, or do they need some extra love? Are there things necessary to get them thriving? So we'll talk about all that. We're going to get some new terms, some new assessment components here. We're going to talk about anatomy and normal pregnancy development and what is not normal, how pregnancy goes bad. Most of them don't. They don't go bad. Prenatal means before the baby is born and the amount of time that mother carries baby. And we know that that's 9 months, but you're not going to think about it in months anymore. As a medical professional, that is out the window. We're looking for 40 weeks. You need to know that. That needs to be written down in your notes. We're hoping that baby is in the womb for 40 weeks. We have 3 trimesters. They're broken up into 3 months, which are 12 weeks. 3 times 4 equals 12. So 12 times 3 at a minimum, we should be coming to 36. We're hoping for 40. You're also going to see the book talk about the youngest you should be before delivering a baby. How low of weeks of development equals non-viability. And then what the maximum is. There's actually too long in the oven. Some really horrible things begin to happen if we start getting to the 42-week mark. So you need to know that 40 is what we're shooting for. 28 is so young that the baby is most likely not viable. And 42 is too long in the oven that the baby is developing too much to probably be delivered through natural processes, and that creates a lot of complications and potential actual fetal changes even after birth. And so you got to know those numbers. They're really important. So we have 40 weeks in the oven. We break that up into 3 trimesters. The first trimester has some things of importance. We're going to talk about it. The second does as well, and so does the third. And we're going to have to remember which problem goes with which trimester. An example of that being placenta previa. So placenta previa tends to be early or late in the trimesters. It is characterized by the placenta attaching in the wrong place. Bleeding occurs, but on a general basis, the baby does pretty okay. We put mom on rest and we up and increase our following of the patient. But placenta previa can be treated pretty well. And again, that's where the placenta attaches to the wrong place. It actually works its way down towards the vagina. And so then there's some bleeding. It's not attaching correctly to the uterine wall. And so then the patient needs to go on bed rest. We need to watch the patient more. And this will probably be a delivery by cesarean and not by vaginal delivery. The big characteristic to remember with placenta previa is that it is pain-free. Typically, it does not come with pain. Placenta abruptio, or abruptio placenta, either way. Abruptio sounds bad, right? It's abrupt. It's acute. It's big. It's a boom. It's a big change. That's typically trauma. Think of a late trimester woman in a significant motor vehicle accident, and the belly gets hit and the uterine wall snatches away from the placenta. That would be placenta abruptio, and you can probably imagine quickly in your head that that results commonly in the death of the baby and even in the death of mom. So, complications during pregnancy, placenta previa and placenta abruptio, those are big ones that we have on our radar. The placenta previa is going to present early or late, and it's going to be characterized by painless spotting and bleeding during pregnancy. That always worries females, right? When suddenly they begin to bleed. You're not supposed to be bleeding in pregnancy. Hint, hint, that's not true. Tons of pregnant women bleed during pregnancy, and they come out to be just fine. But it definitely does worry them. It definitely does make them think something is wrong, and so they will call 911 for that. You're at a disadvantage because you don't have TOCO monitoring. TOCO monitoring is a device that allows us to measure the contraction of the uterus and the fetal heart rate of the baby inside of mom. And so we can actually determine if there's a level of distress of that baby. Is that baby showing signs of shock? You guys don't have that. And so when you have a third trimester female calls 911 for bleeding, painless bleeding, that's very worrisome. You just have to, transport, and you determine if the hemodynamics are okay. If the patient is not showing signs of shock, you package the patient and you transport the patient, and they'll figure out the rest at the hospital. So know what placenta previa is and know what placenta abruptio is. Placenta previa typically goes okay. Placenta abruptio is pretty bad. It can result in the death of baby and mom very easily. Spontaneous abortion and miscarriage. If you did not know, 20 weeks is when we consider the body having accepted a pregnancy. In the old days, it was very common for females not to tell anyone in their circle, their inner circle, that they were pregnant until after the 20-week mark, because there was a very large stigma with if the body spontaneously aborted before the 20-week mark, people would just say you were lying and that you were never pregnant and that you were, trying to maintain your marriage, or you were trying to get a marriage, So there's a stigma that even still today goes along with announcing a pregnancy before the 20-week mark. The point of that being, you need to know that if someone before the 20-week mark calls for, I was pregnant and now I suddenly am profusely bleeding vaginally, that's potentially a spontaneous abortion, and that is a normal and natural process of the body. The body has a way of deciding whether a fetus is developing appropriately, whether it is healthy, whether it is viable, or whether it's harming mom. and it can abort that baby at any moment. So this can also happen after the 20-week mark. We just remember that 20-week mark because that's how long it takes for the body to typically say, okay, I accept that I have this baby growing in me and I'm going to support it. Okay? Ectopic pregnancy, we've discussed a good bit before this lecture, and that is a pregnancy that occurs outside of the uterus. And we know that that's bad. So any childbearing age female who calls for acute onset abdominal pain that's lower in nature, lower quadrant abdominal pain, and they look shocky, we're going to consider that an ectopic pregnancy until proven otherwise, because that's a big killer of our young pregnancy capable women. So we have to be very on top of that being a potential for the patient. Preeclampsia and eclampsia we'll talk about. That's a complication during pregnancy, similar to pregnancy-generated diabetes. That's also a complication of pregnancy. So we'll discuss that. We'll go through what happens when the baby comes out. We talked about that. We'll talk about trauma. I do want to reiterate, as we have already in this class, that you can't lay late trimester females on their back. You've got to remember that. If you do that, you risk that big baby, the big belly, cutting off the returning blood flow to the heart. You can squeeze the vena cava shut and it won't let the blood return to the heart. And so you always want to kind of give a little tilt to the left. You can go in left recovery. You can sit the patient up. You can tilt the backboard a little to the left. This is only a big deal if the patient needs to be supine. Say they're unconscious. Say they're in cardiac arrest. Say you're worried about their spine, and so you've placed them in spine motion restriction. So then that's when this becomes a big deal. And you can't lay second trimester, a little bit less, but more so third trimester women on their back. And as pregnancy progresses, they do this naturally. They don't sleep on their back. They end up getting these big old pregnancy pillows and they're laying on one side or the other, and it becomes, super uncomfortable. But that is a natural thing the body's doing. It's trying to avoid that whole supine hypotension syndrome. And so that'll bring us to our first lecture question. If you're not here live, I would like for you to define supine hypotensive syndrome as it regards the pregnant patient and tell me what we can do to avoid it. Give me some scenarios of when we can avoid it. All right, so you got to know the anatomy, and so I'll let you read the anatomy stuff. We've looked at it before, but we will talk about some of it in here that I think is super big to understand. Like, the baby is supposed to be in the uterus. If you were traveling from the vagina, and some of you boys don't know this, and so this is for you, so I hope you're listening. And if you haven't already read this chapter, when you're reading it, you're going to come to find that they've got some pictures for you, real pictures. So I think, one, you should be aware of that, and two, it's good that we see and understand this process in reality. So let's trace how this whole thing works, because most boys know that the vagina is there and there's a tube inside of it, and that's it. They don't know anything else. So let's make sure we understand how this process works. If you enter the vagina, you go up into the vaginal wall space and you enter the gatekeeper. The gatekeeper that keeps bacteria, invaders, fingers, tampons, anything that's not supposed to be in the uterus, the way it's kept out of the uterus is the cervix. And you need to remember that. The cervix is the gatekeeper to the uterus. It doesn't let anything in there. It becomes really important in pregnancy because we can measure it. Not you, not an EMT. We're going to talk about the only time an EMT can put their fingers in the vagina. There is a time. It's one specific time, and we're going to talk about that. But most often, you never would. But if you're a critical care paramedic or you're an OB nurse, we do cervical assessments of effacement and dilation. The cervix is a very strong and thick muscle membrane that closes and protects the uterus from the vaginal opening. When we get to the point of delivery, it is going to begin thinning. The muscle is going to thin. That's called effacement. You need to know that. So when we begin the labor process, we efface the cervix, and that's thinning of the cervical opening. There's an amount of measurement for that. And we dilate. We go from 0 centimeters to 10 centimeters. And that's dilation. And the gate is opening to let the baby come down. The placenta should attach at the top of the uterus. So let's go through this. The egg is coming through the fallopian tube. The sperm goes up to it and fertilizes it. It attaches itself in the uterine wall, and the baby begins to develop. Eventually, the placenta attaches itself to the uterine wall, and it has an umbilical cord coming from it that goes into the baby's belly button, and that is how we perfuse the baby with blood volume. I want to remind you of the really interesting thing about fetal development. They don't breathe and they don't perfuse their lungs. Imagine how much more blood volume a fetal development baby would need if we were trying to perfuse lungs that don't breathe. So then they don't. Does anyone know how the fetal baby, the little developing little pea pod in there, bypasses the lungs? When it is perfusing, blood goes through the heart and back out to the body because it's already oxygenated. When blood reaches the baby, mom has already oxygenated it, so it doesn't need to go through the lungs to become oxygenated. It bypasses the lungs. Does anyone remember how it does that? No? Well, Courtney? Ish. It's the ductus arteriosum, and you should give a little look at that. It's really cool. So the ductus arteriosum is on the aorta, and so basically it allows the baby to circulate already oxygenated blood by bypassing the lungs. And so babies don't breathe inside of mama, and they don't perfuse their lungs until the baby gets outside into open air. That's really cool stuff. So the placenta has all the nutrients and all of the perfusion. So it's got arteries, it's got veins, and that's running through the umbilical cord. The blood is already oxygenated, and it oxygenates baby running round and round because the baby's heart's beating normally. And mom is feeding that baby. Okay? So in placenta previa, the placenta would start inching its way down here towards the vagina, which it's not supposed to do. And that's what causes that little bit of detachment, and it's what causes the bleeding. And typically, I remind you that it's painless bleeding. Abruptio, on the other hand, would be an aggressive, acute, traumatic detachment from the wall of the uterus. Now, it doesn't always have to be trauma. That's just the common way we would see it. There are other things that cause placenta abruptio, but the bigger one in your head would be trauma. So know the difference between the two. So we go through the vagina, in through the vagina's wall and tubing, and we go up to the gatekeeper, which is the cervix. If you got past the cervix, you'd be in the uterus. In the uterus is where we keep the baby. That's the anatomy that I want you to make sure you at least know. So keep that in mind. All right, that's going to give you a little bit more information on how that works. And again, you're carrying umbilical veins carrying oxygenated blood from the mama to the fetus. And then the umbilical arteries are carrying deoxygenated blood from the fetus to the placenta where mom fixes it, which is pretty cool also if you're looking at the fetal blood supply. By the way, there's some pretty good YouTube videos, illustration videos that show you some really cool fetal development and fetal blood movement, how the fetal blood moves from baby to mom, mom to baby. It's really cool. There's also an app that is completely free, put on by Children's Hospital of Cincinnati. and it's called Heartpedia. Heartpedia is a lot of stuff that really you're not ready for, but it's also some really good stuff. Like, for instance, PDA oriented stuff, the ductus arteriosum. So you can actually look at the ductus arteriosum. On the Heartpedia app, you can look at different cardiac defects, congenital cardiac defects, and it will show you how blood runs through a normal heart of a baby and a fetus, and it'll show you how broken babies' heart's blood goes, so that you can kind of understand what goes wrong. It's a pretty cool app. Not suggesting that it's necessary for this chapter, because it's not, but it's really freaking cool, and it's free. It's called Heartpedia, put on by the Children's Hospital of Cincinnati, which is really cool. So we know that the baby rests inside the amniotic sac, which is about a liter of fluid, depending how big mama is, depending how big baby is, and how hydrated mom is. So we got about 500 to 1,000 cc's of amniotic fluid in there. And all of that is keeping the baby from getting a little too much outside interference. All right. We need to know that mom is carrying higher blood pressure than normal as we progress through pregnancy. Mom is carrying higher heart rates as we progress through pregnancy. Mom's breathing rate will naturally go up as we progress through pregnancy. And that's all because the demand for the baby, that extra thing that you're now feeding and oxygenating, is increasing as we go through the trimesters, as we go through each one of them. So you need to know that the blood volume of mom goes up by, some literature says, about a third. Your book is going to give you a specific that it thinks you should know, but blood volume increases. Why is this important to know? Because since that is a hemodynamic norm in this population, it can be misleading. We are going to have to lose more blood before we start showing the same level of shock that you would have shown if you weren't in a later trimester of pregnancy. So you've got to be of a higher index of suspicion with pregnant patients, because they naturally breathe faster. They naturally have faster heart rates. They naturally have higher blood pressures. And that might lead you to think, well, is this what I should be seeing? Or is this elevation from compensation? And the answer is, it's so difficult to know at the EMT level that you just have to err on the side of caution. Pregnant people should always be encouraged to go get checked out when anything happens, because we just don't know. And a simple TOCO exam, a simple ultrasound, would be able to say, baby's doing fine. Okay, baby's not in distress. And now I remind you again that TOCO is looking at the uterine contraction and looking at the fetal heart rate of the baby and seeing how those two things correlate. It's best used when mom is in labor, but it is also used outside of the labor process to determine how baby is responding to whatever's going on with mom. Okay, so that's TOCO monitoring. The only service I know that does TOCO monitoring for pre-hospital care is Medicare Air, which is we do high-risk obstetrics at our base. I think we're probably the only base that does that in the state. So it's not normal that you guys would see TOCO out there, but it's easy to know what it is and to get why it would be helpful. It's not very helpful to you in your short setting, but you're going to see it. And so when you see it, it's nice to know what you're looking at. When you take a patient in that's pregnant, they're going to immediately go on TOCO. And so, it would be cool that you know what the hell we're looking at. And so the bottom puck, there's a little circle pucks, goes on the uterus to kind of develop whether or not there's a contraction. And then the top puck is looking for the baby's heart rate. So you'll have two little pucks, and they go around the belly, and one's looking for the baby, and one's looking for the contractions, right? So you'll at least know what that is. You can also do Doppler. We have Dopplers, which are microphone enhanced I won't get into the deepness of what Doppler does, but basically you can squeeze a little jelly on the belly, and this microphone makes the fetal heartbeat loud for you, and you can check it. Now, that is common to see on ambulances, so you might see that. And if you're really good, you can also check fetal heart tones with a stethoscope. You got to be careful, though, because it's really funny. The baby's heart rate should be higher than mom. If you're getting a heart rate that's 110, 120, 130, you got to make sure mom's heart rate's not that, right? Because if you listen really close to the aorta in mama's abdomen, that's going to be mama's heart rate, not the baby's heart rate. So that's pretty cool stuff. And that's just cool stuff, not necessarily stuff that's going to be in the chapter. Okay, so it's going to tell you about each trimester. It's going to tell you about going up in some blood volume, going up in heart rate, breathing rate, why moms complain of the stuff that they do complain of. So gestational diabetes is a big deal. We need to make sure we're asking this mom, do you have prenatal care? And has any of this prenatal care resulted in any diagnoses? Have you been diagnosed with pregnancy-oriented diabetes? Have you been diagnosed with pregnancy-oriented high blood pressure? Because those are the things, the most emergent, most deadly things we end up seeing pregnant patients for. So, check sugars on pregnant patients, period. Okay? The gestational diabetes is not the one that's going to get you the most. It'll get you, but it's not the one that's going to get you the most. It's the high blood pressure during pregnancy that is going to scare you a little more. Eclampsia is seizure activity caused by preeclampsia, which is high blood pressure during pregnancy. So you need to know those terms. Preeclampsia, that is when we identify that the pregnant mom has high blood pressure during pregnancy. We need you on bed rest, lay off of the salt. Here's a diet plan. Here's the exercise plan, which should be lay your butt down. Don't be doing anything. Everything should be done for you. You need to be on bed rest so that we don't elevate this pressure anymore. Should the pressure keep climbing and the patient actually begins to have seizures, it would become eclampsia. It's just that simple. Those are the definitions. Preeclampsia is the blood pressure problem that's causing, eventually, if it happens, eclampsia. Okay? Here's the good deal for you. Although these patients do scare you more, it is scary to see a late trimester pregnancy female seizing. That is pretty scary. And that does bring about some more emotions. And it also, you have to remember to turn them on their side, right? Because you cannot have them supine. So that's another thing to work on. The rest of it is the same care you would provide any other seizure patient. We've been very clear that the care for seizure patients is airway, airway, airway. Don't let them hit their head. Don't let them hurt themselves from the tonic-clonic flopping like a fish. And keep control of the airway. We need oxygenation. We need good ventilation. And so then that requires a good assessment. You need to remember your suctioning techniques. When people are seizing, you can't get in their mouth necessarily. So your nasopharyngeal suctioning is a big, important component of caring for the seizure patient. So other than the big belly, other than trying to compensate for supine hypotensive syndrome, the treatment of that seizure for you is going to be the same as if the patient wasn't pregnant. Okay? Maintain airway. Don't let them choke on saliva or vomit or blood in their airway. It's very common for them to bite their tongue, which causes bleeding. It's very common for there to be this thick developing saliva because you're not swallowing like normal. The patient is using their fluid volume, and so it becomes thicker. It's not as clear and easy to run its course down to the esophagus. So it can build up right there in that hypopharynx space, and keep the patient from moving air in and out of their lungs. If patients seize for prolonged periods of time, guys, it is thought, we don't always know, but it is believed that if the brain is in full tonic-clonic seizures, every muscle in the body is firing, we would expect that that is also happening to the diaphragm. And it's also happening to the vocal cords. And so what would happen if they spasm? Well, then you don't breathe. And so you might need to be ventilating a patient who is not stopping like normal. We would normally see a seizure go for 60 seconds, maybe 2 minutes, but not longer than that. If it goes longer than that, you might need to start breathing for this patient. You have to wonder if they're not breathing anymore. So think about that.
You are now muted. You are now unmuted.
All right, so know what preeclampsia is, know what eclampsia is, and be able to discuss what you are looking to do if you're faced with a seizing late trimester pregnant mom. Because it is pretty scary. You're going to have to think about it. You're going to have to focus on it. Okay? You can look at the ectopic pregnancy. I think we've beat that bush a little bit. Abortion can be elected or spontaneous, and it's talking about the 20-week thing. So we've hit that also. We're going to carry on. Pregnant women are at great risk for abuse, and I'm going to leave it there. Pay attention to these women. We need to advocate for pregnant women, and we need to advocate for babies, and that's just common freaking sense. And so, make sure we're doing that. Make sure we're putting them in a safe space to say something if something needs to be said. Okay? Think about that. Don't forget that there's a ton of pregnant moms out there using opiates, pain medications, heroin, stimulants, Adderall, cocaine, and crack. What does that mean for the baby? Well, if you deliver that baby in the field, you're going to see the same addiction, the same result of high for the baby that you would see in mom. So the baby might need Narcan. The baby might need you to ventilate them. If mom was high, then baby is high. So when we're interviewing them for sample and for OBQRST, you ask, how's your prenatal care? Have you been diagnosed with anything during your prenatal care? What was your last ultrasound like? Did that go well? Have you had any drugs or alcohol during this pregnancy? Have you smoked during this pregnancy? Have you been eating well during this pregnancy? Who is your OBGYN? When's the last time you saw them? These are really important questions to ask a mom. Number one, we need to take these patients to a hospital that their OBGYN can see them at. You got to remember that emergency room physicians do not see obstetrics patients. I want to say that again. EM docs, emergency medicine docs, do not see pregnant patients unless they're forced to. It's the same thing for us. We don't run around claiming to be OB neonate specialists. It's a very large field and a difficult field. You only deal with it when you're forced to deal with it. So this is an area we have to learn about because we are a master of none, but a familiar with all. And that's just the nature of our business. We have to know a little bit about everything, but we accept that we don't know a lot about any specific special thing. So EM docs are the same. This patient is going right up to the OB floor. They're not going to be spending time in an emergency room if it can be prevented in any possibility. They're going to the OB floor. So it's important to make sure you're going to where that patient is normally treated. That doc is most familiar. So ask the patient who their OBGYN is. Ask the patient what hospital that OB is affiliated with, because the moment you call into the emergency room with an OB patient, they're going to ask you that if you haven't already volunteered that information. So that's really important. Kiara Lemon, did you have a question? Seems like you put your hand up, but y'all be hitting keyboards and stuff. If you do, just ask it. This is a good space to take a break. We've been going at it for about 50 minutes, 50 minutes, so let's take a break. Lecture assignment, it is 1921. Tell me that. We took our first break at 1921. I just want you to tell me that. And we'll come back at 1930. 1930.
You are now muted. You are now unmuted.
All right. Can everybody hear me? Can everyone hear me? Thank you. Can I get hands up, please? Put your hands up, singing my song. I don't apologize for Miley Cyrus. Jason Eater, are you still alive? Jason? Maybe he had to pee. All right, that's almost everyone. Jason, I'm sure will be here shortly. All right, let's get back to it. We were talking about questions to make sure we're gathering from our pregnant patient for whatever their complaint may be, our additional sample and OPQRST needs. And so that brings us, I see you, Jason. So that brings us to asking patients about previous and current pregnancies. So let's talk about para and gravida. It's important for us, especially if we think we're getting into a scenario where we might have to deliver a baby in the field, to know about how many pregnancies mom has had and what was the result of those pregnancies. Because everything about giving birth and neonates and geriatric care, obstetrics care is statistics based. And so we want to gather information from the mom that tells us, statistically speaking, how we favor. And so if mom is on their first pregnancy and has had no previous children, the first labor is going to take hours and hours and hours. It's not likely that you will be delivering a first pregnancy in the field, unless you catch it really late. They just couldn't get to the hospital, or maybe they were trying to do a home delivery, but something changed. That would be, sensible. It's way more common that you would have a third baby, fourth baby, fifth baby scenario, because once a woman has given birth, the labor process speeds up substantially as the pregnancies count up. So it's important to ask para and gravida questions. Para is how many live births do you have? Or how many children are you the parent to? That's one way to remember that. That's how many children did you carry to term and they were born alive. Okay? Now, that child might have died later in maybe a car accident or something horrible, but it was born alive. Okay? That would be a para. Gravita is how many pregnancies you've had. So if I am gravida 1, para 0, that means I've never had a baby before. I've never had a pregnancy before. This is the only one. And the labor process, if it follows all the rules, is probably going to take a long time, right? If I am gravida 3, para 2, then that means I have 2 children and inside of me is number 3, and we're talking about that child, number 3. And I would expect that child to come more quickly. I would expect the labor process to be lessened in time and faster in delivery, for sure. And so sometimes we can even get into what we call lightning delivery scenario. A lightning delivery scenario, typically you would have a high para count, and mama feels that she is in labor, and minutes after that she delivers. There's no time in between. And that's when you kind of get the interstate babies, where they were traveling and mom went into labor and there was just no time. Suddenly we're delivering baby into the floorboard of a car. That would be a lightning scenario. You want to talk about para and gravida so that you know where you are. They're going to ask you when you call an in code and you say, I'm coming with this pregnant mom who's in labor, or whatever your complaint is, they're going to ask you para and gravida. So make yourself look competent. make yourself look prepared and appropriate for this population of patient by already having this information ready to go for the next level of providers. Because they're going to, one, need it, and two, if you don't volunteer it, they're going to ask it of you, and if you don't have it, obviously that's going to cause a pause, and that's going to be, for you, an awkward pause, because now you've got to go get that information. It looks like you didn't know you needed it. So make sure you know that you do need it. The other thing that we also ask for is abortions. Okay? How many elected abortions have you had? And how many spontaneous abortions have you had? How many stillborn babies have you had? Those questions are difficult to ask, but they're important to ask because, statistically speaking, if you've had elective abortions or spontaneous abortions even more so, then we could be delivering a more in distress baby today. We could potentially be delivering a non-viable baby today. And so if I had the opportunity to make it to an OB ER, I would want to try instead of delivering that baby in the field. I hope you understand the point of asking all these questions is, how emergent is this? Should I be the one delivering this kid? And by delivering, I mean, should we be the one coaching and assisting mom? Should this happen here in the back of an ambulance, or should we be trying our best to make our way towards the emergency room? I got to tell you that if the baby starts presenting, it's yours. You got to stop the ambulance and you got to deliver no matter what, because it's not safe to keep trying down the road and deliver a baby. It doesn't work very well, and it becomes dangerous, and babies get dropped, and babies get hurt, and moms get hurt when we're bouncing down the back of the road trying to prevent a natural process from occurring that's not going to be prevented. Once baby starts entering the delivery process, they will go through that process. There's nothing you can do. So that's important to remember. And the answer to that is crowning. If you can see the top of the baby's head or the bulging of the baby's head in the vagina assessment, when you take a look, if you see crowning, that baby's coming and it's time to deliver. That's the typical rule that we use for should we go or should we stay. And if you're going to stay, we'll talk about what we do. And if you're going to go, we'll talk about what we do. Okay? So that's your assessment features. That is your knowledge of anatomy and physiology and maybe some pathophysiology of what happens during fetal development, what can go wrong during the pregnancy cycles, and what are we looking for? Okay, we're looking for, was there gestational diabetes? Was there prenatal care? Was there any preeclampsia? Has there been any eclampsia? Any drugs? Any alcohol? Any smoking? How's the diet been? Has this baby been okay? When was the last appointment? Are we seeing an OBGYN? Where does that OBGYN practice? What baby is this for you? What is your para? What is your gravita? Are you taking any medications for this pregnancy beyond prenatal health supplements? And they should be taking prenatal health supplements. And every single answer that doesn't go the way you were hoping it went adds a little tick mark to, I don't want to be the one to deliver this baby. This baby might come out in distress. This baby might require resuscitation. Okay? That's the whole point here. Trying to darken my screen a little bit. It's getting a little too bright for me. All right. So that's the conversation there. Any cardiac arrest of pregnant patients, remember that you need to focus on mom. If you can save mom, you're likely going to save the baby. We tend to get focused on how can I treat the fetus. Well, you can't. You can treat mom, which will likely be a linear treatment to baby. So focus on mom. And good cardiac arrest care of a late trimester mom is tilted to the left. Whether that is a 45-degree tilt on a backboard with some, bags, towels, blankets underneath the board, get mom off their back, because you're doing CPR for nothing if the blood can't return to the heart. So think about that. Okay, moving on. I'll let you read about cultural values in teen pregnancy, which is something that's important for us to deal with. Make sure you read the chapter. This is a big chapter. We talked about all the things to assess with our interview of the patient. This slide is a test question. The stages of labor are a test question. You're going to see test questions about this has happened and this has happened. What stage of labor are we in? So let's go through the stages of labor. Stage 1 begins with dilation of the cervix. I told you what the cervix was. And it ends with the crowning of the baby's head. 2 begins with crowning and ends with delivery of the baby. 3 begins with delivery of the baby and ends with delivery of the placenta. That is correct. Somewhere around the 5, 10, 15-minute mark, the placenta should deliver too. And we should look at it to make sure it appears intact, which will be a little difficult for you because you don't really know what a placenta looks like. But if you could just imagine chopped up hamburger that's purple and gray and pink and red instead of hamburgery colors, then that's what it looks like. And it should have even borders, and it should not look like it has been chopped or cut with a knife. Because if there's some presentation of the placenta that looks like it is cut or ripped, then we're worried about a significant infection in mom. And so that would be something you'd want to tell the receiving facility. You need to keep the placenta. It does not get thrown on the floor and left behind. There's lots of reasons for that. We won't go into them. They're not EMT reasons, but you need to keep the placenta. Okay? So know the stages of delivery. Dilation to crowning, stage 1. Crowning to delivery of baby, stage 2. Delivery of baby to delivery of placenta, stage 3. Let you look through that and do the reading. All right, preparing for delivery, we have OB kits in the ambulance. They're required by law. And it has everything you need. It's got chuck pads, which are these really huge absorbent blanket type things, because if you didn't know, this is one of the messiest things you will ever witness in your whole life. EMTs do not have to do any deliveries in the OB clinic before becoming an EMT, but medics do. And one of the things that shocked me the most was just how much fluid and stuff can come with this process. So you definitely want to, if you have time to, put out all those chuck pads and those absorbent blanket-like things that come in the OBGYN kit that's on the ambulance. You want to put that under mom, and you want to put that under your stretcher, because let me tell you, not only is that a mess, but it's a slippery mess that you can't wipe away. And it will make you drop that baby. So you want absorbent materials, whether that's blankets, towels, or the little pads, or well, actually they're big pads, that come in the OB kit. Those things are really important because all that mess will make you drop that baby. So keep that in mind. You need to be in your own PPE. You need to be in gowns, eye protection, mask, and gloves, and probably hair protection, because when the stuff comes, it comes. And a lot of times it's not crazy, but sometimes it is. And you don't want to be finding crazy in your hair 45 minutes after this call. So we have full-blown Tyvek suits in the ambulance. Every ambulance is required to have them. And so if you know you're going to deliver and you have time to do it, get yourself some PPE on your body. When you have someone who's in labor, you want to ask about contractions. When moms are going to actually deliver, contractions should grow in intensity, shorten in time apart from one another, and increase in their duration, the contraction's actual duration, how long it lasted, the beginning of the contraction to the end of the contraction, and then the interval between contraction number 1 to contraction number 2. They should get more aggressive. They should be more of them in less time. So when someone says that my contractions were kind of minimal and they were 15 minutes apart, and now I've had multiple contractions in 1 minute and they're probably 3 to 5 minutes apart. 3 to 5 minute apart contractions equals baby's coming. Okay? So we want to ask about that. That 3 to 5 minute window is worrisome in the regards of us having to deliver the baby in the field. So baby is coming. We're so happy. We inspect the vagina and we find that the baby is crowning. We remember that crowning is the head kind of poking through. It doesn't even have to be all the way through and visible. It can even be bulging so aggressively that we know that that's what we have. Okay, hold on 2 seconds.
You are now muted.
Think you know better? Turn that off. Turn it off. TV upstairs. Thank you. I can't afford the internet drain.
You are now unmuted.
So that's what we're looking for. That tells us we're probably going to have to deliver this baby. Even if all of the stuff we got from our interview suggests maybe I wish I didn't have to. Okay? Again, once it's going, you ain't going to stop it. You should not try to stop it. You should try to deliver the baby. Okay? Here's the OB kit and all the stuff that comes in it, including a bulb syringe, which is really, really important. This tells you how to place mom. Basically, some pillows underneath the head and shoulders. Let's get the legs open, make them comfortable. We're going to start on the back, kind of in an elevated sitting upright position. Maybe not quite semi-Fowlers, but kind of getting close to semi-Fowlers with their hips and knees flexed. And we're trying to, make it, obvious that the baby is going to slip on through here. Lots of towels and stuff. And here's a good position and picturing of mom. This would be, if I can see into the vagina itself, I know that baby's coming. And so we're going to stop doing whatever. If we're still trying to get to the hospital, we're going to stop doing that. Okay. If you need it, you're going to put oxygen on mama. If mama's showing any signs of trouble, don't be afraid to put on a non-rebreather. I was about to say, go ahead and start yourself a line and get you some lactated ringers going, but that's not this class. But get you some oxygen on mama, and it'll help her carry on this labor process longer. Okay? Delivering the head, a little gentle pressure on the perineum, which, if you don't know what the perineum is, it is the tissue between mom's anus and the lower vaginal opening. It will tear if you don't do this. And so we give a little gentle pressure to kind of keep that from tearing. And we help that baby's head just kind of make its way out. So hopefully the sac will have ruptured, but if it didn't, you'll rupture it. Either you'll take a clamp from the OB kit and rupture it, you can tear it with your finger, or you can pop it with your shears, but you've got to get it out. You've got to pop that amniotic sac. If you have to pop the amniotic sac and the baby's already out with us, because sometimes the baby will push the sac forward, the sac will come out first, and then baby's head right behind it, you're going to need to suction the baby immediately. And we always suction newborn's mouth first, nose second. The way you can remember that is that M, Mary, comes before N, Nancy, on the alphabet. M comes before N. But here's the bigger conversation. Why is that important? If you didn't know, babies do not know how to breathe through their mouth. They breathe through their nose. They're called nasal obligatory breathers. So if you were to suction the nose first, that stimulus is going to make them breathe. Well, all that stuff that's stuck in the hypopharynx would then be sucked into their lungs. So you don't want to do that. By sucking the mouth first, you get anything that's in the hypopharynx out, so that when you start messing with the nose and it stimulates the baby to breathe, they're breathing air and not crap. Okay? So mouth before nose. We don't have to suction all babies, but don't be afraid to suction babies. Also, know how to use a bulb syringe. Okay? You squeeze it on the outside and then you put it in and let it go so that it can suck. I cannot tell you how many times I've seen stupid people, and it's always a guy, stupid medics, put the damn bulb syringe in the patient's mouth and press it. That is the opposite of what we're looking for, and it's super stupid. Okay, so squeeze the bulb syringe on the outside, put it in the mouth, let it go. It should suction. Do the same thing for the nose. Mouth before nose. If you are to encounter nuchal cord, nuchal means neck, cord means around it, so you are seeing the cord. That is a very scary, scary thing. It must be dealt with immediately. This is the one time we can get our fingers in the vagina. If you need to try to find that cord and get it out from around that baby's neck, you do what you got to do, okay? So if you see the cord, you are going to slip the cord over the baby's head if at all possible, and the baby should start progressing and you'll be just fine. If you cannot get that cord over the baby's head, you will clamp, cut in the middle. Simple. You can't risk the baby progressing through the canal, because remember, we ain't stopping it. It's going to keep coming, and the more you push that baby, the more that cord tightens around that neck, and it will eventually tighten so much that you can't get it cut or around the head, and you will have killed that child. Okay? So, if you see that cord and you can't slip it around the head, clamp, cut. Normally that doesn't happen. You'll see the head first. Head always comes first. That's what we want. That's not true, but that's what we want. The head will come first. Gentle pressure down. We kind of see the baby rotating their shoulders out, normally from the right shoulder around. Babies typically present head out and head down. And so if that's the case, then we kind of rotate that little left shoulder around and we're moving that baby out, and then the right shoulder, and you'll bring it on out. And it's super fun to do. When they come out, they'll have this little yellow crap on them. That's called the vernix. You might see that on a test question. So pay attention to the fourth line here. That's completely normal. That yellow tinge, waxy type feeling makes them super slippery, and it protects their skin from bacteria and from the environment that they're now in and the environment they came from. So that's normal. When babies come out, we dry and stimulate. We rub their little shoulders, we rub their little chest, and we rub their head and their body, and we're drying and we're stimulating. That is almost always enough for them to realize, hey, I'm out. I need to start breathing. And then they do. Again, you don't always have to suction these babies. That used to be a thing where every baby got suction. We know that that's not really the case. So you deliver that baby, you dry and you stimulate it, and you're looking for the baby to go from blue to pink and mad and screaming at the top of its lungs. That would be best case scenario. Okay? Best case scenario. The cord. Do not cut the cord early. At a minimum, you won't cut the cord until it stops throbbing. The baby's placenta will know that it is done and this is over, and it will stop throbbing. So there's an artery in the umbilicus. There's two veins in one artery. And so you will feel it stop throbbing, and now you can cut it, which is typically just about 7 inches away from baby, put clamp 1. About 3 inches away from clamp 1, put clamp 2, and cut in the middle. If at all possible, the parents should be the one cutting. Grandparents, parent, dad, mom, whoever the hell wants to cut that would be great. If they don't want to do it, then you should do it. But don't be that idiot that takes that moment away, if at all possible. If everyone is stable and baby looks great, screaming at the top of its lungs, then let the parents cut the cord. That's a really cool thing to have in your bag of experiences. So remember, give more room for clamp 1 than less room. Here's why. If we need to give this baby any medications, if we need to do any resuscitation with this baby, the paramedic or the nursing staff is going to start an umbilical vein IV, basically. We're going to gain access to the baby using their umbilical cord. If you didn't leave us enough room, we typically, if this cord is more than a few hours old, then we have to cut the top of it off to get down to the fresh vein that's there. And if you didn't leave us enough room, then that's really not possible. And so you could potentially leave a baby having to get an intraosseous access because we didn't have enough cord. So more cord is better than too little of cord. We can always take extra cord away. So the book is going to give you some numbers. I think those numbers are 7 to 10 inches from the baby, put clamp number 1, 3 inches from that, put clamp number 2, cut in the middle. I don't care about the numbers, just that you know why you need to be far enough away from the baby before you cut the cord. Okie dokie. Baby should go skin to skin on mama or daddy as soon as possible, or whoever the hell else is in the room. If possible, that should be mama, because when babies go chest to chest, baby to mama, skin to skin, some things start happening, like the secretion of oxytocin. Oxytocin is going to squeeze down on those vessels and stop any postpartum hemorrhage. And we really want that. It releases all the good stuff to say, this is over now. And so you should start healing. You should start stopping that blood. And so that's important to do. If at all possible, leave the cord going until it stops throbbing. It says after approximately 60 seconds, there's a lot of data out there right now that is wagering that should be around 10 minutes. 10 minutes, not 60 seconds. And so what we would typically say the measure is if it's not throbbing anymore, then the baby's got all the volume that it's going to give it. There's a ton of data that says cutting the cord too early results in more index of hypovolemia, more trouble, more new life complications in the next 30 days. This kid, if their cord was cut too early, is going to fight a little harder than a kid whose cord wasn't cut early. Now, obviously, if you need to resuscitate baby, then there's nothing we can do. We've got to clamp, cut, go. But if you have a good, happy, healthy baby, there's no reason why we can't take our time with that. There is no rush for that. And so a 5-minute window, a 10-minute window, that would be more along the lines of the new data that we're seeing. Again, if it's not throbbing, then cut it. When babies come out, we assess the baby via APGAR. We do a 1-minute APGAR, a 5-minute APGAR, and a 10-minute APGAR. The 1-minute APGAR is okay to be crap, because when babies first come out, it takes them a second to say, oh, okay, I'm here. I have arrived. It's time to start doing business. I need to close that ductus arteriosum, start perfusing my lungs with blood volume, breathing on my own, and doing my own thing. That takes a second for some babies. And so that dry and stimulate is going to really be helpful. Okay? But we're going to assess them with an APGAR. APGAR stands for appearance, pulse, grimace, activity, and respirations. And the appearance and activity might be in reverse. It doesn't really matter. And each one of these are scored 0 to 2, which makes the APGAR's maximum point value a 10. So 2 times 5 is 10. And as you can see, you can be 0, and that would be a dead baby. Kiara Lemon, do you have a question? You've raised your hand again. Okay, no worries. So at 1 minute, 5 minute, and 10 minute, I would expect the APGAR to initially probably be 5, 6, 7, and moving towards 10 by 10. That's the way you remember it. I should be 10 by 10. Why? In about 10 minutes, I would expect the patient's ductus arteriosum to have given us enough normal circulation support for the baby's oxygenation to be reaching above 94%. When babies first come out, you need to put SpO2 on the right hand, because it is preductal, okay? You can go look at why that matters if you want. I don't think that's going to be talked about in the chapter. I don't think you're ever going to be quizzed on that, but you need to do that for reality. We put an SpO2 on the right fingers of the baby, or right side of the baby, okay? In 10 minutes, I would expect that SpO2 to be normal, above 94%. Maybe not 96, maybe not 98, maybe not 100, but by 10 minutes, above 94%. So if a baby is 1 minute old, it's not going to have an SpO2 that you like. It's going to be in the 80s, maybe even 70s. And you're going to think, oh gosh, that is completely normal because this kid has not been pushing blood to their lungs. And now there is no mama giving them already oxygenated blood. They got to do it themselves. And that takes about 10 minutes for that process to fully resolve and become big boy process. Okay. So 1 minute APGAR, 5 minute APGAR, and the 10 minute APGAR. By 10 minutes, I'm expecting an angry baby. I'm expecting a crying baby. I'm expecting a pissed off baby. And that makes me happy. Okay. Skin to skin contact. Even if possible, start suckling. Because all that suckling, all that skin-to-skin contact releases good oxytocin and starts the process of mama's healing, which is really good. Okay? Let's get a little deeper into the delivery of the placenta. I'll let you look at that. It's not gonna go into APGAR yet, so okay, I'll follow with them. I won't breach from the protocol here. So we've delivered the baby, we're doing our APGARs, and we're keeping an eye on mama. Any bleeding beyond 500 cc's post-delivery of the baby is postpartum hemorrhage. If a woman's going to die from labor, it's going to be from postpartum hemorrhage. We have to have an eye out for it. What do? Oxygen, treatment of shock, fundal massage. The fundus is the strongest, most contracting part of the uterus. It's at the top of the uterus and it feels very tough to palpation. So you will go to that tough, hard uterine top and you will gently massage it like you're kneading bread. What does that do? It secretes oxytocin, which will cause vasoconstriction. It will squeeze off that bleeding and tell the body, okay, this is done. The gravity process is over and we are ready to stop this bleeding. Okay. So how do you do that? Fundal massage, skin to skin contact with baby. If possible, baby should try to suckle, try to breastfeed that baby, which doesn't always happen in the first hours of life. And if you can have it happen, then you get more oxytocin out of that. If that doesn't work, then your paramedic's going to need to give oxytocin. And so ALS backup's a big deal here. So know why we do fundal massage, know what fundal massage is, and know that postpartum hemorrhage is considered an emergency if bleeding exceeds 500 cc's. Which is not an abnormal number to you because we've kind of used that as our reference point throughout the course. More than 500 cc's of bleeding makes the body recognize this is bad, we're in trouble, let's start the shock process. More than 30 minutes elapse and the placenta has not delivered. Very concerning because I start wondering if that's going to be the source of bleeding. Okay. Dry and stimulate, dry and stimulate, dry and stimulate. Rub that baby's chest, rub the back between the shoulder blades, rub that back real good. What we don't do is smack the baby. That is 1994 and minus 20 years. So we don't do that anymore. We dry and we stimulate. And if needed, you suction that baby. Okay, it's not always needed. Mouth before the nose. So let's get into APGAR. Heart rates of neonates. Neonates are babies that are born and they're probably no longer than 30 days old. A neonate should be a heart rate definitely bigger than 100. Okay? Definitely higher than 100. And if that's true, then they would get a 2 for pulse. Because 2 is as good as you can be. 0 would be less than 60. It needs CPR. 1 would be less than 100, but greater than 60. And 2 would be 100 and higher. I'm happy as I can be, right? So you need a heart rate of 100 or better. If not, we need to start breathing for this baby. You dry and you stimulate, you dry and you stimulate, and you feel that brachial pulse, and we don't have a heart rate greater than 100, we need positive pressure ventilation. Simple as that. Maybe the baby's taking a little too much time to adjust to the breathing environment, and we need to stimulate that baby. Here is the newborn care resuscitation, and it's pretty simple. They come out, we dry, we stimulate, maybe we suction mouth and nose, baby starts improving. If not, if the baby's still blue all over, if the baby's not breathing on its own, start breathing for it. On room air, by the way, on room air, you don't have to use oxygen on babies. Okay, because they don't like it. They don't like oxygen. You can cause them to get worse, not better, if you use a bunch of oxygen. So your protocol will probably say start ventilating on room air with positive pressure ventilation. And this is a kid that you really want to watch for chest rise. You do not want to overventilate a neonate. So 1 breath every 3 seconds, and you do not want to overventilate a neonate. So keep that in mind. So if the heart rate's not above 100, positive pressure ventilation. If the baby doesn't want to breathe enough, they're not above 20, positive pressure ventilation. Okay? If the heart rate drops below 60, start compressions at a ratio of 3 to 1. Compress, 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 breathe. Compress, 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 breathe. Compress, 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 breathe. That is neonatal CPR. Okay? Neonatal CPR, if the heart rate is less than 60, start compressions. If breathing is less than 20, think about whether you should be breathing for this baby. If the heart rate is less than 100, you should be breathing for this baby. Okay? Any questions about neonatal resuscitation? Your ratio is 3 to 1. No questions about that? Okay. Do not forget that you can feel the pulse in the umbilical cord. You can also listen to apical pulses by listening to the baby's left ventricle with your stethoscope. Those are really important things because peripheral pulses are difficult to find on neonates. And so it's not uncommon for apical pulses to be the going thing. That is almost always what we do in my line of work. But if you have a nice umbilical cord room, and the baby has a good perfusion, then you might be able to detect the heart rate in the umbilical cord itself. All right, there's your 3 to 1. There's your CPR. Meconium. We're going to get back to APGAR. Meconium staining. If the baby ran into distress during the labor process, it will poop. It will poop. And if it poops, you'll see weird looking colorations in the vernix and the fluidiness over the baby. You will tell that there's some extra stuff there. I almost said shit, which would have been appropriate because that's what it is. If you see meconium and the baby is not breathing, then suction the mouth, then the nose, and start PPV. If the baby is breathing, then you assess the baby. Then it becomes a normal baby. Here's the point. Meconium is not the end of the day. It used to be. If you saw a meconium-stained baby, we thought that baby should be intubated immediately. They should be suctioned via intubation. Potentially, they should go on a ventilator. They need big, broad-spectrum antibiotics. We used to think that was a big damn deal. And maybe it is. But for whatever reason, some babies troop right on, and it's not a big deal, and they do just fine. So if the baby's not breathing, if the baby's not progressing, suction, suction, suction. Breathe, breathe, breathe for the baby. I don't know what's going on with this cat. If the baby is doing just fine and you happen to notice meconium, then just note it. It's just noted. If the baby is nice and pink and crying and happy and screaming and trying to punch you in the face and they happen to be meconium, then that's a meconium baby that won't need any love. That's fine. Okay? So it's not the end of the day. If the baby's not progressing, you know what to do. APGAR, here we are. Appearance, pulse, grimace or irritability, activity and muscle tone, and respiration. So appearance is about color. You have to learn the word acrocyanosis now. Cyanosis means blue, and acrocyanosis means peripheral blueness, okay? I am blue in my periphery, but I'm pink in the core. That is normal for your 1 minute APGAR. It is normal to find a brand new baby blue in the periphery, but starting to pink up in the core. That's great. Okay, so appearance is about color. If the baby is already pink and happy, then that would be a 2. If the baby is acrocyanotic, so they're pink in the central, but they're blue in the periphery, that would be a 1. And if the baby's blue all over, that would be a 0. Pulse, is it above 100? If it is, 2. If it's below 100 but above 60, 1. If it's less than 60, the baby needs compressions and it gets a 0. Grimace or irritability is about facial expression and how strong of a cry they have. So I want to see angry face. I want to see old man angry face. Babies should be pissed off. We just took them from the most cush spot with all of this amniotic fluid, just keeping them all warm, and they're so insulated, and there's this big, protection. There's not loud noises. And now we've got them in this hyper stimulated environment. They should have angry face and they should be screaming. So if the baby is screaming with angry face, it gets a 2. If the baby has a soft, almost cry and not much facial grimace, then it would get a 1. And if the baby's not crying and the baby has no grimace, it would get a 0. Activity is about the amount of fight in this baby. We love to see babies fighting, throwing their arms and legs and kicking and swinging. That is great. That would get a 2. If the baby is only moving when you stimulate it, when you mess with it, it kind of moves, that would be a 1. And if the baby's not moving, it would be a 0. Respirations should be above 20, and they should be vibrant, great volume. And so if that's true, it's a 2. Less than 20 would start looking at a 1. The baby's breathing, but it's, not as great as I want it to be. It's not as good in volume. And then obviously, if the baby is, breathing less than, I think the book quotes 10, but any amount of breathing that you think is shallow and not working, give that a 0 and start positive pressure ventilation. If you get all 2s, you would equal 10. If you get all 0s, you'd equal 0. And so I'm hoping to see a baby around 7 at the 1 minute mark, around 9 or 8 or 9 around the 5 minute mark. And by 10, I should have 10. There you go. There you go. You are going to see APGAR scores on testing. Breech delivery is anything comes out but the head. we want to run, okay? If the process doesn't go exactly as you wanted, run. Start emergent transport immediately because it's likely the baby will have to go into an immediate cesarean. You can't do that, and so you need to run, okay? If the baby is presenting and progressing like normal, everyone's smiling, and we all get to go on the news for a completely natural process that none of us have the right to take credit for. But if anything presents outside of that vagina, not ahead, run. You'll read the different complications that it lists. I'm going to let you go through these little disorders. They're not super big for us. They're just kind of knowledge base. Do remember to ask the mama if this is twins. No one likes to be surprised by the delivery of second baby without notice. That's a little silly. So we're looking for newborns to be about 7 pounds. Okay, if you look at that from a kg perspective, which I hope you can do, 7 divided by 2 minus 10%. So we're looking at probably 3.5 kgs for most new neonates that are full term. They were in the oven as long as I wanted them to be. Any newborn who delivers before 8 months or 36 weeks and weighs less than 5 pounds is premature. So 36 weeks is premature. 32 weeks is a big cutoff for most hospitals. Most regular hospitals cannot keep babies or intentionally deliver them at the 32-week mark or less. They need to go to a high-level nursery, a level 4 nursery. So 36 weeks is a happy spot. 40 is the best. 28 weeks, I don't have any lungs developed, and so I can't breathe, and so I'm going to die, okay? Or I'm going to probably present dead and never even be, viable from the beginning. So just remember that, guys. You got to keep that in your mind, because if you show up at a house at 2 a.m. and there's this little bitty almost baby-looking alien thing in the toilet, which we find commonly, guys, and this is a 25-weeker, and there's no sign of life, do not try to resuscitate that. You can't save it. All you will do is create false hope and prolong the coping process for this family. Do I expect the EMT to have enough experience in this population to have your wits about you? Probably not. I'm not going to freak out if you do something like that, but it would be great if you could remember that a baby that presents 28 weeks or before and doesn't have any sign of life is a dead baby. And so don't work it. And of course, your local protocols and guidelines will always take precedence over any training. So you do what they say you do. But it's important to know, when is viability? Typically, we accept that outside of the womb, viability is around 28 weeks. Will you be able to go on the internet and search for babies that were 22 weeks and survived? Yes. Are there many of them? Absolutely not. They're huge and abnormal outliers of the data. So, take that into consideration. There's your little difference. So any pregnancy lasting longer than 41 weeks is starting to be too long in the oven. So that's a big deal. I'll let you read that. Remember that we always cover the vagina with bandages with gentle pressure. We do not pack the vagina. You do pack other wounds. You do pack points of articulation and joining to the extremities. You do not pack a vagina. Are you going to see doctors pack vaginas? Yep, I've seen it many times. But that's what they do. They're OBs, and that's on them. We don't do that. Put a 5x9, gentle pressure, and start counting. How many 5x9s have you gone through? I'm on 5x9 number 10. Well, that's a big deal. You can actually do some research, as I've told you before, and you can look up how much the average 4x4 can hold, how much the average 5x9 can hold in blood. So that's important. You don't discard them, we count them. Know the things that tend to happen to mamas after delivery. It is not uncommon for postpartum cardiomyopathy, heart failure. It's not uncommon for postpartum pulmonary embolus. There's a lot of hemodynamic stuff happening when you give a human being life. There's a ton of stuff that happens to that mama, and this mama's now got to go back to just supporting one person instead of 2 or 3 or 4 or 5. So you got to think, if you go to a call for any complaint and they tell you they gave birth 2 weeks ago, it better be on your radar that something might have happened secondary to postpartum syndromes, whether that be heart failure, whether that be pulmonary embolus, whether that be STEMIs, heart attacks even. Okay, so think about that stuff. It's really important. I have seen a couple patients post-delivery go into flash pulmonary edema. If that blood pressure is huge, the lungs are sounding like rails, there's fluid, they're complaining of trouble breathing. I can't breathe, I can't breathe, I can't breathe. What do you put them on? Answer that question for me. You hear rails, they're postpartum, they're swollen ankles, they can't breathe, you're sad as crap on a non-rebreather. What do you put them on? Very good. CPAP. It's the only thing that's going to move fluid. You can throw all the oxygen you want down the airways, but if you have fluid covering those alveoli, they are collapsed. They don't have the ability to exchange oxygen. You need that pressure behind that oxygen to build those alveoli back up, give them life again, and make them do their job. So do not forget the power of CPAP. CPAP is your thing. That's an EMT thing. They fought for you to have it. You should own that arena. You should know everything there is to know about CPAP because it's yours and it's important for you to defend your scope of practice. All right, you answer the questions. Very good. It starts with dilation of the cervix. It ends with whatever presents to us first. We hope that that's crowning. So A is correct. 23-year-old woman, 24 weeks pregnant, first baby, edema in hands and headache and visual disturbances. This is classic for big blood pressure. And then you take one and here you go. Big blood pressure, dizziness, edema, headaches, visual disturbances. She's most likely experiencing what? You guys are right. Pre-eclampsia. Pre-eclampsia is the big blood pressure. If it's not fixed, if we can't resolve it, we're going to run into eclampsia where they begin to seize because of those blood pressures. You are transporting a woman who is 8 months pregnant. To prevent supine hypertensive syndrome, what you going to do? Correct, D. I love when you guys pay attention. This is such a good class. Immediately after delivery of the head, you should what? Suction mouth then nose, suction nose then mouth, assess the baby's breathing effort and skin color, or check the position of the umbilical cord. This is a sneaky one. So the book was very clear. We don't have to suction all babies. Most babies come out and they do their own business. They take care of their own selves and they start screaming and yelling and fighting and busting ass. And so we're so happy. We don't need to suction all the babies. So the first thing to do is make sure that the baby's not going to die. D, C, then if needed, A. So this is a sneaky question. Whatever presents first better not have a cord attached to it. Then look at that baby. Where are we at in the process? Does it need suctioning? If so, then A. So it should be D, C, A. If anybody was on B, I hope you know why that would be wrong.
You are now muted.
9 o'clock is bedtime. Oh, nope, you're on the punishment. So yes, you better be in bed right now. Love you too. Good night, Jenna. Did you brush your teeth? Okay, I love you.
You are now unmuted.
Upon delivering the baby's head, you know the umbilical cord is wrapped around its neck. You should what? Make one attempt to slide the cord over the head. I like that answer. Immediately clamp. Well, no, because we said most cords can come over the head. So I like B because most times you can slip that cord over the head, and B is the answer. I want to remind you guys, if you cannot get the cord over the head, cut, cut, cut. And if needed, if you feel that cord around that baby's head and it's not out yet, you need to create a V with your fingers between that cord and the baby's head and neck. Because even if you cut that cord, you don't know where the tension is. If mama continues to push, and they will, guys, because it's very hard. Once this begins, it's so hard for mama not to push. We tell them not to, but they can't not. It's like having diarrhea. You can't not. And so they're going to push again. And if you cut that cord, but the tension is in the wrong place, the cord cutting won't matter. So this is the one time, if you feel like you cannot free that baby's cord from that neck, and the baby is not progressed enough outside of the vagina for you to be sure it's not around the neck, put your 2 fingers in the vagina and create a V with your index and your bird finger to keep the cord off that neck. Give the carotid arteries free flow to the brain. Everyone's like, well, you got to make sure they're breathing. They're not breathing. Babies don't typically breathe in the birthing canal. That's not the point. You don't want that baby's brain not getting blood because that cord is strangling the carotid arteries. If the baby's breathing, great, then that becomes another reason. But importantly, that baby's brain won't get any blood, and they will be brain dead. They will be an anoxic baby. You'll have a great heartbeat and a blood pressure and a pink baby, and they're broccoli. That's done nothing but hurt families. So this is the one time you might stick your fingers in the vagina. If there's a question about why, how, when, bring it up. The need for and extent of newborn resuscitation is based on what? Well, the most global answer is D. I mean, ultimately, the parts of APGAR is what makes that decision for us. But this is the most correct and global answer, so D. The 1-minute APGAR of a newborn reveals that the baby has a heart rate of 90. Okay, so that's not 100, so I'm going to give it a 1. A pink body, but blue hands and feet. Okay, so that's acrocyanosis. So I'm going to give that a 1. So now I'm at 2. Rapid respirations. Okay, that's 2. So now I'm at 4. The baby is crying when you flick its feet. You had to flick its feet, though. Remember, we said they're supposed to be angry and crying even when you aren't messing with them. So I don't know how I feel about that. Right now, I'm going to give it a 1. And if that doesn't add up to the answers, I'll give it a 2. So I'm going to go with 1 for now, and that's a 5. And so when I look at the numbers, there is no 5. So then I know that they're wanting me to give a 2 to the baby crying when you flick its feet, and it's resisting straightening its legs. So it's got good tone. And so I'm going to go with 6. And somehow we we reached an 8. So let's see what they came up with. I probably forgot one. Let me look here. I got pulse, that's P. I got pink body, blue hands, that's appearance. I got respirations, that's R. I got the grimace, and I must have missed one, so that's why I lost count here. Oh yeah, I lumped activity in with grimace. And so I should have had a 1 and a 1, or a 1 and a 2, because their activity was good. So there you go. You gotta, now in real life, of course, we would have out our resources. For the test, you're not going to have those resources. And so most people in the room are going to come up with 1 or 2 points of each other. It is still a little bit subjective. There's no way to make these scores completely objective. So try to do your best. Remember the score enough to know worst and best and the parts and how many parts can be assigned at a minimum, and then try to work your way through the score. You'll get good at it. Here's the good thing. These are level 3 and level 4 questions, and so these are the most difficult kind of questions. And if you get these wrong, it doesn't have a lot of weight on the exam, and so that's good. So the correct answer is 8, and their rationale is you should have picked 8. The most effective way to prevent cardiopulmonary arrest in a newborn is to what? Why do babies die? We take this all the way back to our BLS CPR class, and we said that the reason we change things up in the CPR of kids is because their airway is the problem. If you make sure they're breathing and oxygenating, you will keep them from dying. That's statistically the truth. While assisting a woman in labor, you visualize the vagina and see an arm protruding. She tells you she wants to push. What do you tell her? Thank God they didn't give you any stop her from pushing stuff. They just gave you the only obvious good answer here. Neither one of the keep pushing answers is smart. If she keeps pushing, you're going to keep breaching. So that's stupid. So B and D are out. C is for the wrong thing. That's for nuchal cord, and this is a breach. We're not dealing with a nuchal cord. And so the only answer left is A, which is really funny. I guess if you had an Alaskan transport and you were like 2 hours away, then that would make sense. But it is so funny to me that they want you to treat this like internal bowel. The arm of that baby is designed to be exposed, but maybe they're talking about long transports. So A it is. It's the only one that made sense. A newborn is considered term if it's born after blank and before blank. Kind of a crappy question because we know that the real number is 36 and 41, right? 36 and 41, but it's telling you after and before. So you got a plus and minus 1, which I think is an asshole move from the question. And so that would bring you to B, right? We want it to be after 37 because 36 was the cutoff, and we want it if it's too long, it's after 41, and that would be 42. So B would be the answer. All right, guys. Probably one of my favorite chapters in the entire book. I absolutely love obstetrics and neonatal medicine, which is odd for a gay guy to say. But it's one of those things in emergency medicine that is still so manual and so tactile. And if you make good choices, you really do have a really high chance of a positive outcome. Accepting a congenital defect, which is rare, an anatomical anomaly, those are rare. This is a baby that has a brand new heart and brand new lungs. It wants to live. And so the reason I love obstetrics and neonatal medicine is that if you make these good choices, you're really going to be able to save the patient. You're going to see your work immediately. So do read this chapter, a wealth of knowledge in this chapter. Definitely a population you do not want to get caught having to treat and not have been prepared. It's going to make you nervous. It's going to make you less able to be decisive and error in the behalf of the patient, both of them, mama and baby. Never be afraid to call for ALS backup, guys. Never, ever, even if you realize once they get there and they came 20 minutes away that you don't need them. I don't care. And they're going to gripe at you and they're going to be pissed and they're going to call you scared and they're going to say, you don't know what you're doing. Who cares? Error on the side of your patient. Never be afraid to call for ALS backup and never be afraid to call for 2 ambulances. You have 2 patients. And if you're starting to interview mom and she's telling you history things that worry you, you're starting to tick the boxes that say, I shouldn't be assisting delivering this kid in the field. This is a hospital kid. Then call for another ambulance. You don't have to be in a scenario where you're managing 2 patients alone, you and your partner. Okay? Any questions about this chapter? Okie dokie. Let's come back at 8:50. At 8:50.
You are now muted.
just makes me happy. That sounds a little biased because he's my boyfriend, but he really is. He kind of wows me, and I don't know that there's many that have as much courage as he has sometimes when calls are really tough, and it's just really cool to see him shine like that. Anyways, disclaimer, I know nothing of the intimate details, so there's no HIPAA violation there. Anyways, we're going to do pediatrics now and finish the lecture up real quick. I don't know what default is. That doesn't make sense. Why is that on there? I clearly selected 35. You get you. If pages exceeded the maximum. Okay, fine. And then let's delete this one then. Clear errors. Delete that one. Bring up this one. And upload. Okay, that's coming. Can I get some hands up in the air, please? Let me know that you're still here. We're missing one person. There we go. All right. Lower those. And pick this. And that. Nope, I don't want that. To understand why. Clear errors. There's 34. Okay, delete that one. I don't want that one. I want this one. Maybe this is one of those that the slide itself is too many. Be uploaded. To be uploaded. Upload. Let's see if it will do it. Convert file. It's basically saying that it's too big. Yeah. So then I will go to screen share then. Stand by. I will go to Meet. If I have to use that one, I will. Doesn't hurt my feelings. Alright, guys. I'm getting it here. It's wanting to be a jerk because the slides are more than 200. With Alright. I'm just going to screen share with you now. that up. Sorry about that. It took me a second to make it do what I wanted it to do. And we're screen sharing. Remember that when I'm screen sharing, I can't see any of your comments. So if someone starts commenting or needs something or raises their hand, please let me know. I'm going to be quick about this chapter, although it is a big chapter. So please don't let my quickness, as I've said before, insinuate that this is not going to require a lot of time from you, because it is. Here's my point. It doesn't take me 2 seconds to tell you how to go about looking at children. And so I'm going to talk to you from the big takeaways that the National Registry really drives home on kids. Step 1 with kids. In the general impression, remember that when we form a general impression, we come from that perspective as I walk up to the patient. What do I see? Does the patient appear very sick to me or not very sick to me? In the pediatric world, we come from the perspective of the pediatric assessment triangle. The pediatric assessment triangle is how you form a general impression on pediatric patients. I'm going to get you to that slide. Here we go. So this is your general impression on children. Remember that general impressions do not require your hands. When we took the assessment module exam, they honed in on that general impressions don't require your hands. It's what you do when you walk into the room. Well, this is how we do it on kids. Appearance. Do they look like they're lively? Do they look good in color? Work of breathing. If they're working hard to breathe, are they good in tone? They're moving about. They're acting awake and alert. Circulation to skin. Do they look pink? Okay? It does not require you to touch the patient. You need to know what the pediatric assessment triangle is. The beginning of this chapter talks about children being different from adults. And you can't ask children who the president is, what day of the week this is, what's, where are you at right now? You can't do that. So the only way you can assess the mentation of a child, which is in the beginning of your primary, is to come from the perspective of where are you developmentally? What is normal for a 1-year-old? What is normal for 5? What is normal for 10? That's how you approach children. If they're old enough to answer their own questions, let them answer their own questions. You should be interacting with them, okay? So, remember the developmental stages. This chapter is going to open up with reminding you about developmental stages, and you've got to pay attention to that. So do review the developmental stages. Let's get into what really gets children hurt or sick, okay? You need to remember the following acronym. Stable. If you have a child in front of you, there are some core principles to remember as to what goes wrong with children. 1, airway, airway, airway. If it's a problem, it's probably airway. The rest of that conversation in your head is stable. Sugar, temperature, airway, which of course is a huge talk in that conversation. Blood pressure, labs, which you don't really have, and environment, and, encouraging mentation stuff about family and well-being, and where did you find the kid? Is this child in a diaper at 20 degrees outside? When you go in the house, did you not see any food? So remembering that children are super susceptible to neglect and abuse. Super susceptible to neglect and abuse. You're going to see multiple quiz questions and test questions about abuse in children. Okay, so stable, stable, stable. Stable is a class that you can take. and it's for advanced providers. But I think that the acronym in and of itself is really helpful in the idea of a high risk, low frequency population. If you're already going to be very nervous and all of your feelers are extremely, up and going for this population, you're going to a kid call, you hear this bad information over the radio, and so you're thinking, gosh, we're by ourselves and we're going to this really sick kid. And stable, stable, stable. Get a sugar, get a temperature, maintain airway and ventilation. What is the blood pressure? What should it be? Consider the environment for the kid. That acronym is going to help you not miss important things in children. Okay? So let's talk about what the blood pressure should be. We know what the sugar should be because the sugar for children is the same as the sugar for everybody else. 70 to 120. Now, arguably, the younger you get, you start working from 60 to 120. And then when you get into the neonates, it's 40 to 120. Okay? So neonates can be happy at 40. Okay? Neo 40. You don't got to remember this. This is just information. Children, young children, can be happy around 60. And I don't even like that because they burn sugar faster. So we shouldn't spend a lot of time being okay with low-end sugars in children. So I don't want to get too deep into that because it's a critical care conversation, but just know that their tolerance level is a little lower. So 40, 60, and then 70 is the adults, right? So that's the sugar conversation. Temperature is the same, obviously. Airway, we know how to deal with that. We think about maintaining airway, suctioning, opening. So let's talk about that airway perspective from children. Children's heads are bigger than adults. Their airway is different than adults. You're going to see a lot of talk in this chapter about the airway in the child being different. You need to read the defining differences in the child airway compared to the adult. The big one is going to be that the occiput is much bigger. Another big one is going to be that their tongue takes up more airway space and it's very floppy. It gets in the way. The point being, it's harder to get a supraglottic airway on a baby because their tongue is a lot more to manage, okay? And you don't have as much space. Not to mention that unlike the adult, as you progress down the airway of an adult, it opens up and starts becoming greater in diameter. Children's airways become a funnel where they actually get smaller at the opening to the trachea. So you go from this small mouth and it squeezes in even smaller once you get to the viewing of the epiglottic space and the hypopharynx. You're coming into a funnel and then it opens up a little bit more, but not as much as the adult. And so their airway is different. Because it's different, you got to manage them differently. You can't do head tilt chin lifts on young kids. We're talking neonates, we're talking 1-year-olds, 5-year-olds, and less. They don't tolerate head tilt chin lifts because their airway is so small that amount of flexing of their airway or hyperextending of their airway into a head tilt chin lift will just close it, not open it. So what do? It's supposed to be forward. Picture a neonate laying down on the ground. The head should come up above the chest. Okay? Keep them on their back and stack towels underneath their head so that the ear, the bottom of their ear, makes a direct, invisible, imaginary line to the trachea. So there's not a head tilt chin lift position where their chin comes back towards you at the airway. This is raising the head up above the chest line. Okay? If that doesn't make sense, speak up so that I can explain it better. The book has some pictures of that. It's a sniffing position, not a head tilt chin lift. Dominique, what's your question? Are we supposed to be seeing your screen? No, you're not. You're good. We're just talking through stable right now, which is practically almost the entirety of this lecture is stable. Okay, so those are the components about the airway that you need to pay attention to. Big tongue, big occiput, that head is big. It is not going to do well in supine position. Because the back of their head is so much bigger, when you lay a kid supine, they just touch their chin to their chest, and that closes the airway. I'm going to go back to that picture because that picture is actually included in the lecture material and in your book, and I want to show you that. So here we are. You're looking at supine position for an adult. The airway's open. Supine position for a child could potentially put their chin towards their chest and close their airway, simply because that big old head accounts for so much more body surface area than it did in the adult population. Okay, so takeaways. You can't do head tilt chin lift position the same. You got to do head forward above the chest line. Okay, so put towels underneath the head, maybe put some towel rolls underneath the shoulders. If you do that, you're going to find your ventilations with a bag valve mask to be much more efficient. You're going to get more compliance out of your BVM. Okay? The tongue. It's going to be a lot more floppy, a lot more aggravating. So you're going to have to be comfortable controlling the tongue to place your pediatric king tube. The best way I think the EMT could probably get by is using your rigid Decanto suction catheter in your left hand and your king tube in your right hand. Gain control of the tongue with the suction catheter. That way you can create a hole to shoot your king tube down. If you've got that tongue by its base with the suction catheter, then you can pass that king tube, okay? And we've looked at that in the classroom on the adult mannequins. I've shown you using your OPA to help you get a king tube and using the rigid suction catheter to help you get a king tube. If you want me to show you that again, bring it up this week during lab and I'll do it again. Because the way we're teaching you in the testing environment is not necessarily is easier than it actually is. The tongue of the mannequin has form and rigidity. The tongue of a pediatric patient does not. And so it can fold backwards into the airway and become an obstruction for your king tube. So that's a little more conversation happening in your head. There's definitely a higher level of skill required managing the airway of a pediatric patient. That isn't to make you fearful. It's to make you prepare yourself. It's to make you say, I want to practice getting the head position right for BVM ventilations. I want to practice using my suction catheter to control the tongue of my patient. That's how you get these difficult populations under your control. Not by fearing them, but by being prepared for them. Okay? So those are the airway conversations to have. Let's go to blood pressure. So we're just going down stable. We're working our way down stable, and we're talking about all the things that apply as we get to that component in stable. Blood pressure. Blood pressure in kids should be age. Let me see which way I'm going to tell you. I'm going to tell you the book's way. 70 plus 2 times the age. Okay, so you gotta follow, please excuse my dear Aunt Sally. So if you're bad at math, then maybe this doesn't work out for you. So you gotta get that right. And we know that we do 2 times the age first. So if this is a 6-year-old, 6 times 2 is 12. The minimum the systolic can be is 70 plus 12. Okay, which is 82. That would be the minimum systolic you would allow before you would say the patient's blood pressure is too low. Okay? So that's a little thing that helps you remember the blood pressure. You need to know that. 70 plus 2 times the age. Okay? The book is going to talk about that too. So you need to know it. Now, we have resources. I'm not expecting you to memorize all the different vital signs of neonates, toddlers, children, adolescents, but you do need to understand the grand conversation that children breathe at a much higher rate. Neonates can be breathing up to 60 times a minute and that be normal. Heart rates are in the 120s, 140s, 150s, and that's normal. You need to know that the younger they are, the higher those vital signs are going to be at their norm. Okay, and we have these cute little ways to help us remember that the blood pressure of a neonate is very low, and that's normal. So 70 plus 2 times the age. You don't typically like to see blood pressures less than 70 on anybody. Okay, so that's a good starting point. So a blood pressure is 60 to 70 systolic on a brand new baby. That might make sense. But if I got an 8-year-old in front of me, I need 70 plus 16 because 8 times 2 is 16 and 70 plus 16. That would be the minimum systolic that I'll be looking for. So 86, almost 90, which is where we are with the adults, right? Because an 8-year-old, per the AHA, in the world of resuscitation, is starting to be in the adult category, moving out of child and moving into the adult category. So remember 70 plus 2 times the age as your minimum blood pressure, systolic. We're only talking about the systolic, okay? So that's the blood pressure of stable, which brings me to this. Children are your most susceptible, I would say the very young and the very old. So the children are the most susceptible to nausea, vomiting, and diarrhea times multiple days. They don't want to drink and they don't want to eat when they're sick. It is not uncommon for children to be hypovolemic from dehydration after a couple days of being sick. Diarrhea, vomiting. You need to always, always, always think about hypovolemia. We're talking about volume here. We're talking about hydration status in children. So when you see blood pressure unstable, I hope in the back of your mind you're connecting that to the fact that one of the most common emergencies we see in the pediatric population is low volume. They're dehydrated. Okay? They need a lot of nutrients. They burn through a lot of oxygen. They burn through a lot of sugar, and they burn a lot of fluid volume because their metabolic rates are so high. So connect those things to blood pressure. On the environment side of the fence, I would remind you about the book's focus on abuse of children and the neglect that children can face. When we are privy to view a car or a house, it is important that we note normal things. They were clean. They were clothed. They had appropriate air conditioning, whether it was cold or hot. There was groceries. There wasn't a stove left on. There wasn't fire hazards. There wasn't, huge safety hazards. You saw firearms out and they were unsecured. These are really important things that as a servant member of the public, as we are, we can't stay silent on. We are supposed to advance and ensure the safety of our communities. That's what we do. So environment, think of that component. E also stands for emotional support. Remembering that we can't save all children. We have SIDS deaths, which is when a newborn baby dies and we don't know why. We don't really know why. We still don't know why. We have lots of theories, and they say keep your baby on your back until it's this age. Don't let it be on the tummy when it's sleeping. They say don't let there be anything in the crib. Don't put any stuffed animals, and you got to use a certain kind of mattress. I mean, there's all kinds of stuff out there that suggests a connection, a correlation to SIDS death, sudden infant death syndrome. The truth is we don't really know. And so if you go to a baby that's very dead, they're in rigor mortis, you can't move the jaw, the chest is a rigid concrete wall, you can't do CPR, you shouldn't be trying. You need to remember that dead babies are just as dead adults. And that's not easy to swallow, and I wish there was a more palatable way to say that. But you are giving false hope, and you are putting yourself through more emotional stress, and the providers around you to initiate resuscitation on something that cannot possibly be saved. And so that's something to think about. Emotional support means calling a chaplain. Emotional support means staying on scene until the family gets other family members there to be with them. That's emotional support. Some children have congenital defects and they're going to die. We knew they were going to die from birth. So there's a lot that goes into the emotional side of it. Children bring more emotion to us. They're young, they have life ahead of them, they haven't realized that life, and so there's a lot more that goes into the loss of a child. I think not more valuable, but emotion that goes into that we need to EMS should take a second and make sure we're accounting for that component, I think. And the book thinks, and that's what Stable also talks about. So please commit Stable to memory. In a high-risk, low-volume scenario, much of what you will have available to you is what you have committed to muscle memory. Repetition, training, preparation is what you will have available to you when you are at your most stressed, most physically and mentally taxed position. That is what we do. That is how we live our lives every day if you're going to be in the field of emergency and critical care medicine. This week, a young lady is going to jail for making a medical error in administering a medication. We commit things to memory, not to test you, but because what we do is stressful, and humans are built to error. We are in our natures mistake makers. How do you train that out? How do you fix that? The answer is muscle memory. We must do things the correct way every single time, even when it doesn't matter. And we must take these acronyms that we use to heart. They are there not to help us memorize a test, not to help us gain certification, but to, in the moment of stress, when the patient needs us most and we are the most scared, and we will be, and you will be, no matter how strong you are, you will need those acronyms. Please commit Stable to memory and go through Stable every single time you have a child in front of you. Go through each individual part of that. I also want to remind you that everything about kids is weight, height, sex, and age based. There are lots of little helpers out there in the emergency medicine world. I'd like for you to go look at the hand TEVI system. I'm going to make this your discussion post. I would like you to look at Certidose. Let me make sure I'm giving that to you correctly because I don't want... Yeah. So that's just one version. Certidose is just one version, and you'll know what that means when you look it up. And some of this is more ALS than it is BLS, but I want you to notice it. And Broslow tape has always kind of been out there for us, okay? And that's BROSELOW tape. These little things give us a quick way of knowing what is the patient's weight, what medications and what dosages and what amounts to give these patients. And so you're going to see this on every ambulance. And when you have a bad pediatric call, you're going to take this length-based tape, you're going to put the head of the patient here, wherever the feet land, pink, red, yellow, blue, orange, green, it tells you a ton of information. What size king tube to use, BVM techniques. It has a ton of information on it. So I encourage you to take a look at the Broslo tape. They're on every ambulance. There's a version on every ambulance. And this tape has preset, accurate information about that child because children in ideal body weight develop based on age and sex and height. So, in theory, if you can quickly measure the height of that patient and know if they're male or female, yeah, that's all you need, sex and height, then you are quickly able to give general norms of equipment, medications, volume of medications. And so it takes a bunch of the fear and the uncertainty of calculation out of the scenario. So I tell you this for two reasons. One, you'll need it. Even if you're on a truck of EMTs with just EMTs, you'll need it. It has stuff for you too. But two, in the heat of the moment, sometimes these things are forgotten. Be the person that says, hey, should we bring out the Broslo tape? Hey, should we bring out the Hentevi tape? Hentevi is Peter Hentevi. It's not with an H. Peter Hentevi is a physician in Florida. He's incredible. He's a pediatric board-certified emergency physician. He also does adult emergency, and he is the medical control physician for numerous large agencies, fire EMS-based agencies in the state of Florida. He travels the world doing lectures on pediatric emergency medicine. He has done a lot of studying and a lot of calculating on the fact that pre-hospital providers feel more capable with pediatric patients than they ever are in real life. And he went out proving that. And he invented a system that he thinks, that many agencies think, make us better pediatric providers. I encourage you to go take a look at that system. And just familiarize yourself with some of the tools that we have out there that help us treat this special population. Okay? So let's go through the slides real quick and make sure there's no honking piece that I missed that I want to touch on. I'm just going to quickly go through. We talked about pediatric assessment triangle and that replacing your general impression. When you do your secondary exam, your head to toe, if we're talking medical or trauma, it's not uncommon for you to go foot to head. It doesn't really matter, but you can see pediatric patients breathing better when you're looking from a stomach view because their little chests aren't as obvious. Their little bodies don't show as much mechanical as maybe you see in an adult. So it's not uncommon for you to hear us say, go toe to head, go toe to head. And so the book may talk about that a little bit. Give that a little bit of your time and see what you think. All right, we talked about what's different with the airway. I'm going to let you look at the vitals ranges. Maybe some of that might find its way on the test, but I don't think you need to grossly commit those things to memory. Remember that children do not do well without oxygen and sugar. They do not do well without oxygen and sugar. I do want to talk about seizures. So, seizures in children below the age of 6. I hope that you have been taking notes. If you are, number one, you're smart. And number two, put that down. Seizures below the age of 6, if you can tie that seizure to a fever, that's a febrile seizure. Febrile means fever. And that's normal. It's normal to see that. Febrile seizures are seizures that occur in children below the age of 6, not because of how high the temperature gets, but because of how quickly it goes from one temperature to this very high temperature. That will cause a child to seize pretty quickly. These seizures are normally very brief, and they do not normally result in as much of an altered postictal mental status. We remember from the neuro chapter that postictal, P-O-S-T-I-C-A-L, I think I spelled that right in the air, postictal is the period of confusion after a tonic-clonic neuroseizure. You don't really see that as much per the literature, per the book, you're going to read this. You don't really see that period as much in children. And so these febrile seizures should be very brief. They should not result in as much confusion in the child. However, in my experience, anecdotally, it tends to exhaust the crap out of the kid. And so, although I may agree that the kid doesn't not know where they are, or they don't remember their mama's name, or whatever the hell you come up with as far as where their developmental stage of answering questions should be, they are super lethargic, and so that in and of itself, for me, is some amount of postictal. Never forget, when you have a patient who's had a seizure for any reason, you need an oxygen sat and you need a sugar. When you have seizures, you burn through your sugar really fast. You burn through your oxygen really fast. So then you should be ready to replace those things. So get a sat and deal with it if you need to. Get a sugar and call ALS backup if you need to. Now remember, with post-seizures, they're probably not going to be able to follow your commands. So you may not be able to give oral glucose to a low sugar post-seizure patient. So there's that component. But febrile seizures, less than the age of 6, typically very brief, tied aggressively to a fast change in temperature. We need to ask mom about Tylenol and Motrin. Have you done it? What have you been doing to treat this fever? Has the child been sick? And then do the normal things you do with seizures. Maintain airway, maintain ventilation, suction if needed, check a sugar, check oxygen, give it if it needs to be given. Treat for shock, emergency transport. Same stuff over and over and over. It requires thinking, it requires paying attention. So that's febrile seizures in children. Typically goes away by the age of 6. You don't find 10-year-old kids, typically, statistically, having febrile seizures if you were reading the literature. Don't forget to check the skin. Skin is very telling in children. Also, capillary refill. Can anyone remind me what capillary refill should be? What should capillary refill be? I remind you that capillary refill, while Eder is answering my question, is pressing hard on a spot, normally the fingernail beds, the forehead of a pediatric patient, and when you press down, it turns white because you pushed all the blood out of that space, right? And then when you let go, it fills back in. It should take less than 2 seconds for that. Capillary refill, arguably, is most reliable in children. It's not as reliable in adults as we age above 50, 55, 60, 65, because that capillary process slows down and it weakens as we age. In the pediatric population, they're very fast about moving blood and shunting blood and being able to put volume where it's supposed to be in a moment of compensation. So, don't forget to check capillary refill in kids. It's very reliable in the pediatric population. Okay? So there's that. Oh, make sure when you're transporting children, we're obligated to keep the same laws for securing patients in appropriate transport methodology. You can't just put a kid on a stretcher and go. If you have an accident, you better have secured that child in a manner that complies with the law, or be able to articulate an emergency that was so significant you couldn't have, like maintaining airway or resuscitation. You can't just do anything because you're in an ambulance. So we do carry them in car seats. We also have commercial devices like PD-Mate and the Neo Mate. Those are commercial devices that let us quickly secure pediatric patients to our stretcher in a way that complies with federal and state mandates and Department of Transportation requirements. So remember that. If the car seat from the parents is intact and appropriate, bring it. Secure it to your stretcher and use it to transport the patient safely. Don't forget that you can immobilize children in car seats by stacking the area around the child with towel rolls and preventing spinal movement. As long as the car seat is intact and it has not been injured or damaged, it is able to be used to, one, transport the child safely in an ambulance, and two, help immobilize the patient. Traditional immobilization equipment on children does not tend to be successful because they fight it. It scares the crap out of them and they start fighting it. I would argue that maintaining spinal motion restriction, if a child is fighting, is not going to happen. And you're going to be worse off trying to force it than you would if you didn't even try it. So keep that in mind. You've got to find a way to articulate yourself with children. Let's talk about the illnesses that the chapter is going to want to talk about, which is croup and epiglottitis, two airway diseases that we tend to see in kids. All right, if you got your note-taking material out, here we go. Croup, C-R-O-U-P. Croup is viral. It's basically para-influenzal. It's about and around and through the process of flu. And it inflames the upper airway. The test question will say, seal, bark, like, cough. Seal like the animal, S-E-A-L. Seal, bark, like, cough. At night, these kids will get this horrible cough that just goes nuts at night, and they'll call 911 for respiratory distress. And so, has the child been sick? Have you heard this really horrible cough? Is this worse at night than it is during the day? If you see that in a test question, seal, bark, like, cough, think croup. Here's the conversation. Anyone doing that obviously has a bunch of swelling in their airway. Keep them calm, oxygenate them the best that you can, and emergently transport. They need certain medications and treatments you don't have. And so the best thing you can do is keep them calm and emergently transport. Do oxygen to the best of your ability. Get the parents involved to help you maintain assessment and an oxygenation of the kid. Maybe you do blow-by. Maybe you have parents hold the mask. Maybe the kid doesn't care and they let you put them on the mask. But you got to think about these things. So that's croup. Seal, bark, like, cough, worse at night equals croup. Epiglottitis is the really scary one, okay? Both of them can be really bad. Both of them can go downhill. But epiglottitis is the one we really worry about. Epiglottitis is normally bacterial. Epiglottitis is normally bacterial, and it is direct inflammation of the epiglottis and the surrounding tracheal opening tissues. The ticket here is drooling. If you see the test questions say, the kid's been sick for a couple days, it's been progressively getting worse, very lethargic, worse at night, and the kid's drooling. The drooling comes from the inability to swallow without great pain. And they're trying to breathe. So if it comes between breathing and swallowing, I'll just stop swallowing. And so then the drool literally just falls out of their mouth because they can't swallow. It hurts to swallow and eventually even becomes almost impossible to swallow. And so they tend to drool. Again, keep the patient very calm. We're talking young kids here. Don't get super worked up and lights and sirens and calling 20 people in the room. You got to keep your head about you. Get oxygen on board the best of your ability, keep the patient calm, and emergently transport. The stuff this kid needs is not typically in the back of your ambulance, and it's not typically in the back of mine. So you need to use your head and stay calm and emergently transport the patient to the best of your ability. And when I say emergent, I mean whatever modality is not going to upset that patient. So if mom's holding the kid, mom keeps holding the kid. If dad's holding the kid, dad keeps holding the kid. You don't need to take the kid. You don't need to cause the kid to cry. You can do all the things you need to do with the help of mom and dad or whoever the caregivers are. That's almost always true. Okay? There's no need for you to come in and detach children, especially when we're thinking croup or we're thinking epiglottitis. So, in review, two of the big airway things that go wrong with kids, croup and epiglottitis. Croup, seal bark like cough. Epiglottitis, drooling. Croup, seal bark like cough. Epiglottitis, drooling. That is the test HELP. If you don't remember that, you will miss those questions. And they are coming your way, I assure you. Here's the 70 plus 2 times the age. In children, they're breathing such at a higher rate, you cannot do divided by 4 or 15 seconds. You need to do 60 seconds or at a minimum 30. You know how to do airway obstruction. We've gone through BLS. Don't be afraid to hit these kids with some albuterol. If it's wheezing, give it albuterol. The indication is wheezing. Give it albuterol. Let mom help you. There's the cup trick. They love to talk about the cup trick. Remember stable, 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 stable. Don't forget capillary refill. It's so powerful in children. There's AEO tips, AEIOU tips, and some of y'all asked me, do I need to remember this? Well, yeah, it's good to remember this. Am I going to give it to you on an acronym quiz? No, I'm not going to, because some of you are frickin' struggling with sample and you should be ashamed of yourselves. But moving on, I'm not going to give you AEIOU tips because I don't think I've ever seen it show up in the psychomotor examinations or in the computer-based examinations. However, it is important in trying to assess why a person has altered mental status. And so it's something to think about. We already talked about seizures. We know how to manage it. You are going to see some meningitis questions and focus on the blotchy red skin. Nuchal rigidity and blotchy red skin. If you have meningitis, which is the covering over your brain and spinal cord, you do not want people to stretch your spinal cord. Well, touching your chin to your chest would stretch your spinal cord, and that would be very painful. So one of the tests that we do to suggest whether someone does or doesn't have meningitis is we ask them to touch their chin to their chest. If they can't do that, then that worries us. Or extend your legs all the way out. If you don't want to stretch your body into a supine position, that would also worry me. If that's painful, that would worry me. The red blotchy skin, very telltale for meningitis. Make sure you have on your PPE because this is airway and contact driven. So gown, gloves, mask, eye protection. Don't forget dehydration in children. Don't forget volume in children. Delayed capillary refill. When you see CRT, capillary refill. Lethargic and delayed CRT, you should always have volume on your mind. Children are not supposed to be lethargic, guys. Unless it's a bedtime, if you could articulate that it's bedtime, fine. Outside of that, it is not supposed to be lethargic. They're very crazy, go-getter, always psycho, always wanting to be up and awake. And if that's not what you see, it should worry you. I'm going to let you look at the injury pattern abuse talk. I'd give that a little bit of my attention if I were you. Don't forget the rule of 9s for burns changes in children because their body surface area is different. Their head is bigger. Their thorax is smaller. So look at the rule of 9s again. All right. One last thing. I hate that we do it this way because you don't even know regular triage yet. The one big difference in jump start triage and adult start triage is the way we determine who gets care first when there are multiple patients on scene, right? You can't care for everybody. You got to find out who's got the worst injuries or illnesses and treat those people first, right? They're the ones that should get your equipment and your time and your energy. So how do we determine who gets what? Well, triage. That's how. Start triage. The difference in pediatric patient triage and adult triage is that if we find a kid not breathing, we would open their airway. If they do not breathe, we would give them 5 rescue breaths. And then we would categorize them. In the adult triage, you open the airway and they don't breathe, they're dead. That's it. I need you to remember that difference. That is the takeaway. We will learn about triage in the operations module, and I will hit this harder. But right now, I just want you to know the difference between jump start triage and regular triage. In jump start triage, we know that kids are an airway-driven problem. So therefore, we need to give a little bit of love to the airway component. In jump start triage, we would open the airway. If they aren't breathing, we would give them 5 rescue breaths and see if that stimulates them to breathe. If it doesn't, we would label them a black tag or expectant, which means they're dead. And if they do start breathing, we would label them red, and we would try to put in an adjunct to maintain that airway open. Okay? So, in start triage, there are no breaths given. In jump start triage, in the pediatric patient, we do give those extra breaths. That's the difference. Pay attention to that algorithm. I'll let you read that. Here's the child abuse mechanism. You are gonna potentially see quiz questions about AEIOU tips and about the child abuse thing. I would like to bring you to some of the big ones. Delay in seeking care. If that arm was broken yesterday, huge concern. Here's another one. Unconscious kids are considered child abuse unless proven otherwise. There is no excuse for an unconscious kid without a medical reasoning except abuse unless proven otherwise. There's a big deal about shaking kids and their brains taking an insult. The external outside of this patient will look fine. The vitals will look fine. There's no sugar problem, no temperature problem, there's no blood pressure problem, there's no hemodynamic problem you can find. But this kid is unconscious. That is child abuse until proven otherwise. We need to get this kid to the hospital so that investigators and doctors can figure it out. We would scan that patient and look for abuse signs on CT imaging. That's what we would do. So pay attention to unknown etiology, unconsciousness. Etiology means the origin of, the cause, the source. Unknown etiology, unconsciousness in kids is a sign of abuse. Delay in seeking care is a sign of abuse. If ever you think a kid needs to be seen by a doctor and the family says no, you find a calm, professional, and deliberate way to get law enforcement on that scene. Shaken baby syndrome. Read about it if you don't know about it. ALTEs. This is important. ALTE. ALTE. If 911 call goes out, my baby's not breathing. Everyone comes running, and we get there, and this baby looks great. They're pink, they're mad, they're happy, they're talking, they're cuckooing and cacaing, and we're all like, this baby looks great. Don't believe that. Something happened. If a child suddenly loses consciousness, turns colors, and stops breathing, in their early stages of life, it can be very indicative of certain congenital defects and anatomical anomalies. ALTEs are to be investigated extensively. The fact that when we get there, this child looks great means nothing. Do not let that family think that they are safe to refuse transport and then put that baby in the bed and go to sleep. Ain't happening. We have to find out if this ALTE is the sign of a bigger thing, okay? Especially if an ALTE occurs during breastfeeding or bottle feeding. Especially if an ALTE occurs during breastfeeding or bottle feeding. If a baby attempts to suckle and loses consciousness and changes colors, there is a hemodynamic cause. That needs to be investigated. So, point to be taken. If you get a call for a very scary baby not breathing, blue, unconscious, unresponsive, we're starting CPR, and you get there, and this kid looks great all of a sudden. Don't believe that. Encourage that family to go to the hospital. Encourage them to investigate that. And the reason is Alti. All right. How does the pediatric airway differ from the adult anatomy? Anyone, unmute your microphone and give me your answer, because I can't see you in the chat.
D.
Did you say B Bravo?
D as in dog.
D is in dog. Thank you. Because B would be a lie, right? So D as in dog is correct. Their body surface area is accounted for grossly in that big old head. They have a big old head. When a small child falls from a significant height, the blank most often strikes the ground first. Well, we've said it 100 times. The head. It's bigger, it's heavier. That's what hits the ground first. Oh, my bad. When assessing a conscious 9-year-old, you should, well, this guy's 9, so let him talk to you. Respect his age and development, and let him talk to you. B. The purpose of a shunt. Okay, so we didn't really touch on this, but you probably know. When kids have trouble equalizing the pressure in their head, when they get constant ear infections, we'll put in eustachian tubes to drain and depressurize their head for them. And so these shunts can become clogged, and it will result in high fevers, very altered mental status, potentially unconsciousness, and significant infections. So if you go to a kid and they tell you they've got tubes in their ears and this kid has a screaming fever and a huge headache, that's an emergency. This is a potential surgical emergency that needs to be corrected. I'd probably think that shunt is in trouble, okay? So the shunt does equalize pressure and drain fluid away from the ears and sinus cavities and all that stuff in your ear, nose, throat connection, away from that space into the peritoneal space. So the purpose of a shunt: minimize pressure within the skull. Reroute blood from the lungs? No. Instill food directly to the stomach? No. Drain excess fluid from the peritoneum? That could be true. I'm thinking A would be the best answer here. And there you go. A ventriculoperitoneal shunt, simply called a shunt, extends from the ventricles or the cavities in the head into the peritoneal space, which is in your thorax. The VPs shunt excess fluid. So this is a hydrocephaly kid, kids that have water on the brain, or kids that have a lot of ear infections. They're not draining well, so this helps drain. Which of the following statements regarding febrile seizures is correct?
D.
Most febrile seizures occur in children between 2 months and 2 years. Ish.
D as in delta.
Okay, thanks. That's better. Seizures from febrile typically are short, and they don't have as much confusion. That's true. If you guys don't start using Alpha, Bravo, Charlie, Delta, I'm going to have to do some extra manipulation maneuvers during lab. That was my politically correct way of saying assault. You respond to a sick child late at night. The child appears very ill. There's high fever and drooling. What is it?
Charlie.
Epiglottitis. We said drooling equals epiglottitis. Treatment for a semi-conscious child is swallowed an unknown quantity of a pill. Semi-conscious. So you can't give them activated charcoal. That's out. You can't give people stuff in their airway that aren't conscious. Monitor the child for vomiting. Give them oxygen transport. That always sounds good. Position the child on their left side. Elevate their feet. We don't elevate their feet. That's stupid. Contact may control. Request permission to induce vomiting. We do not ever induce vomiting. So the only good answer here is Bravo. When using the mnemonic child abuse, what does the D stand for? This was one of the big ones I said we should pay attention to.
A.
Alpha, very good. Divorced parents does not cause child abuse. Delay in care is a big deal. 4-year-old, second story fall, lands on head, unresponsive, slow breathing. That's not good. Large hematoma to the head, bleeding from the nose. You should.
Barley.
Yeah, I like Charlie. It's the most global, and I don't see anything that's wrong with it. So, Charlie it is. AVPU, the P is what?
Barley.
Yeah, pain stimulus. So the patient's alert to you painfully stimulating them. Big chapters, guys. Huge chapters. Welcome to Special Populations. Certainly one of my favorite parts, but arguably some of the most difficult parts of the class. So do give it your time. If you have no questions for me, I will see you Wednesday and Thursday. I'm flying tomorrow. If you're bored, come out and see me. Bye-bye. Have a good night.
Thank you.
Thank you.
Thank you.
Thank you.
You are now muted.